Go for it.
So we had a fun discussion in the corner regarding potentially how can we think about using data from the standpoint of clinicians asking, if we have a thought about an observation, how to find data sets and collaborators. And on the other end, if you are, for example, a statistician who needs a data set, how to do that. And we talked a lot using the example of prostate cancer and active surveillance, how we did that over time. And one of the things that came out that didn't come out in my presentation very well was because we had a large data set, Scott Ziegler from the School of Public Health just fortuitously said, I would like to try Bayesian statistics and a Bayesian model on your data set to see if we could do better. And he did, and that led to the app that shows for patients, et cetera, that patients use and physicians now use as part of Epic to show better predictive models. So actually our conversation in our group turned to how do you create those types of interactions that we all struggle with to find how do you merge people up. And one of the things that Sue and Porterfield and we talked about was, is there a way that we can actually create a curated source of the Hopkins data sets that might be available to be studied by people like Scott who are looking for data sets? And could we put in, as investigators or people who own those data sets, the questions we're currently looking for answers, help with? And this is an ongoing struggle at the university, at all universities and all places. How do you find partners? And so we thought, again, the big thing we talked about was, are there ways should we create a new resource that says, here's the data sets, here's the questions, we're looking for partners. And we also had an interesting discussion about how can you create the best interfaces for that, because it's actually not just saying here's a list of data sets, but is there a way to almost create an app that would maneuver you through to want to use the data sets and the psychology of that. One of the guys in our group was a psychologist who said, there's a science around that. How does Facebook get you to use their app? And can we apply that to some kind of grand experiment to our own data sets? And could the Malone actually do some kind of pilot around, is there actually a way to create a vehicle by which we would actually merge our clinical questions with the data scientist questions? So I'll stop there. That's what we have found.
No, I think that's great. I've often myself had the same thought that there's an incredible wealth of data, there's an incredible wealth of problems around this institution, but there's no centralized way that I could ever identify compatible data and problems for the sort of research that I want to do. So I guess at some level you want to create a data dating site for Hopkins.
Yeah, and it's almost an experiment worth doing.
No,
Sue, do you want to say anything else about that, or did I cover it? Anytime I can give somebody else a job that's not mine, I'm all for it.
I love it. That's a great outcome. All right, Peter, I guess now the mic has been passed to you.
Okay, so we had a very diverse group of people coming at the issue of information technology from many different angles, and I always find that refreshing and really good because you can get into your own mindset about how to approach something. So I'll divide it through three ways. There was a lot of discussion about stakeholder points of the person suffering with the disease and how they see the utility of information, medicine, the clinician, and then there's the scientist. So from the patient side, there was a lot of discussion about what does all this information mean? You can be as precise as you want. You can tell me that my brain is atrophying 0.1% per year, but what does that mean? How does that impact my decision making? And there's a huge need for thinking that with functional outcomes. So the rehab doctors who was there, rehab engineer, to user-friendly devices to help a patient assimilate all this information and put it into a format in which they can be better educated to make decisions about whether they want to go on toxic medications or not. We discussed how people can look at the same data and come to very different conclusions. So it makes us interesting, different human beings, and so that there would be, I asked Mission great need for an app that would help facilitate patient decision making and risk assessment, much in the way we have cardiovascular risk scores and scores for cancer. We need something for neurologic disease that is going to be user-friendly for that. From the clinician side, we heard a lot about information overload. We had one young clinician and one more wise clinician, and very different viewpoints. So I think, and I can speak to this a little bit, being sort of somewhere in between, that Epic was really hard for me because I wasn't used to technology, and now things are coming at me in clinic in 20 different directions. I have to fill out information, and I like looking at the people I take care of, spending my time counseling them. So there's almost too much information. We don't know which of it's relevant, which isn't, and it's overwhelming for people who are in one era, and in the younger era, they're sort of used to it. They're very attentive, but it takes away, we heard from the young clinician that it takes away from the humanism of medicine. And somehow we have to develop a way of assimilating all this information such that it makes us better, more humanistic doctors rather than robots. And so I give the example, there's an app that tells you about drug interactions. So rather than my having to look them all up, you can enter them in, and it shows up, oh, you have a drug interaction. You spend less time reading and more time face-to-face with the patient. But we have to develop a way of entering all this information and not having it distract us from taking care of people. So that's the clinician side. There need to be people who think about making the electronic record more user-friendly. And then on the research side, the PhD physician scientists and biologists, all this information can be used for discovery biology and looking at patterns that we don't know necessarily what they mean. They're probably not ready for the clinical side, but just, as Ken mentioned, if we have people look at this big data and draw attention to patterns, we can go back and test these hypotheses either in the laboratory. If we find a gene that predicts brain atrophy, we can look at the function of that, or we can start setting up longitudinal prospective studies to validate what this information means. And yet, we sort of right now are overwhelmed with the amount of data, so we need to work with the information technologists to assimilate it. Really interesting to see the different viewpoints around the table, that it all completely.
Well, I mean, really, what I take away, like particularly from the first two, is we've got a lot of data out there, and there's the patient consumer and there's the physician consumer, and right now we're not doing a particularly good job of distilling data for either of those consumers in a way that either gives the patient kind of decision-making power and comfort, or the clinician giving them, as you say, both the humanism but also the understanding that lets them communicate effectively with the patient. So do you think, like in multiple sclerosis, is there a targeted direction that you could take that?
Yeah, so I was mentioning that recently people are trying to develop either apps where the patients can enter information in an iPad. In our precision medicine center, they actually enter their information in an iPad. They can upload it into their electronic medical record. So they're doing it on their own time and not on clinician's time, and then hopefully that will populate in a dashboard that can be looked at quickly. We're trying to develop educational tools so that people don't have to be assimilating this information when they're nervous and hearing about a diagnosis or a bad prognosis for the first time in the clinic, where we know that 80 or 90% of what a physician says to the patient is forgotten by the time they get home. So if they can access this on the internet at home, then they can assimilate it in their more comfortable setting, be able to talk more about to come back with just a question. I think we need to sort of figure out how to, someone called it the digital advisor, sort of like.
I was thinking digital dozen.
Yeah.
It's like in the museum, right? The person who knows what the story behind things.
And there's discussion about having virtual trainers for people with disease-specific modules, so that basically our patients would like to exercise, but they get fatigue. Fatigue is an overwhelming symptom of early MS, and so counseling them regarding ways of counteracting the fatigue, being able to pursue a healthy lifestyle. And there are approaches to this, just like with Peloton, using bicycles now, where you have a virtual trainer that's in New York City who's looking at your numbers, and some of it's automated and some of it actually is live, where someone's actually looking at the data and how fast you're pedaling. We could do this in a disease setting, I think, and so rehabilitation and physical therapy for MS is sort of using virtual trainers, electronic telemedicine is something that can improve access to the system, because basically the academic neurologists only see about 10% of MS, and most of it's out in the community. And so we need to have ways of sort of getting the information out to all the community.
Excellent. Well, let's do that. All right. Adam?
Again, thanks to the group who participated in a very lively discussion that we had. I think we began by trying to talk about just a way of view for talking about organization for engineering improvement in healthcare. And we began examining what the role of the engineer and the role of the clinician will be 20 years from now, what ideally that might look like. And that was surprisingly productive discussion. I think we came up with maybe 4 key principles are the ones that I'll highlight now. The last one was that if we could develop an exemption in our current consent process that would allow the use of medical information in a prescribed way at the School of Engineering and the university and within the hospital, it would eliminate some substantial barriers to collaboration and to productivity that we have now. And that's something that I think is under consideration now. The idea being that we should be able to technically allow engineers in the lighting school and be able to use patient data behind the firewall in a consented way properly. One of the our early action items would be to try and promote engineering education at some level to clinicians in their training process, and similarly to promote medical education to engineering students in their training process. And that might be as simple as offering for warehousing opportunities for internships in the medical fields for engineering trainees, or introducing some core engineering principles, systems engineering principles in the medical school curriculum. Well, both probably fairly low cost and maybe highly effective at getting us to where we thought we might need to be 20 years from now, where we foresee engineers having a much greater healthcare impact and clinicians still being the hands on the patient and really leading the evaluation processes. We also, there was a suggestion that we really needed a prioritization schema for recognizing what were the important questions that needed to be answered or the problems that needed to be solved. And since everyone in our group would probably answer differently when asked what do you think the important healthcare problem is, it was just that what we really need to have to step back and develop a palette of questions that we might ask clinicians, patients, and family members, 2 different palettes. Because what we perceive in healthcare as a problem, those on the delivery side might have different perceptions than those on the receiving side. And then finally, I think in terms of healthcare information portability as a barrier to both care and development of engineering solutions, there was this idea of using marrying the formal security that banking systems have now to allow wide deployment of your management resources and easy accessibility of those management resources to groups of people who you trust on a daily basis with your financial information. Those people actually may know more about your financial health than you do, just like a patient-physician relationship, and you have a trusting relationship, and you still have control of that information and data. So that was an interesting suggestion for the path forward.
Excellent. Thank you.
Okay.
Alan?
So we had a live reading session.
I see that. You got a lot of writing on the paper.
Yeah, took a lot of notes. It was both ranged from the very practical to philosophical.
Mm-hmm.
We even had a mention of George Orwell's 1984 application. Just to give you a sense of how some.
That's in the past, though.
It wasn't. So I'll just hit on a couple of highlights here. We talked about the fact that the clinical operations is both an area where we can apply technology, but also device innovation at the device level. So almost there's a little bit of the dichotomy there, that both are related, but our conversation went down both pathways, clinical operations, but also device innovation. Maybe spent a little bit more time focused on clinical operations and how to apply technology there, in the sense that data and information flows to various people and through various systems. It's important to think about where that data and information flows, and then operations happen scattered throughout the entire healthcare enterprise, and it's important to understand the operations in each one of those areas and how they may or may not interact. A major theme of the conversation was the importance of, we use various terms, surveillance, flight data recorder, data logging, and I think we really kind of centered in around the conversation around using technology to collect data in a smart way to enable precision and value, applying technology to improve precision and value. And while I hear that, I totally understand we're collecting a lot of data already, and that why do we need more? I think that the nature of the conversation was figuring out what do we need to measure and collecting the appropriate data to answer the questions that we may want to address. There's a lot of challenges with that, including we sometimes don't know what data we want until it's down the road. And then there's also cultural and privacy-related kinds of things related to data collection that everybody, that's what the 1984 thing came up. Everybody can raise concerns with it and demonstrate some resistance to. But we also recognize the importance of using that data to understand when things went wrong, but also understanding when things went right. And then in order to capitalize on that data, you need the right teams of people brought together, not just clinicians, but engineers and other economists and insurers have to be a part of the conversation as well. So the importance of having the right teams of people looking at this data and collecting is another theme that we talked about. In addition to collecting this data to understand what went wrong, but also went right, there's value in collecting baseline data over time. Developing these new solutions, we need something to compare it to. And a lot of times we'll have developed something and realize we don't have anything to compare it to. And that's unfortunate.
Hard to know you've improved something if you didn't measure it to start with.
Right, so dwelling up front, that would be an important thing to do.
Excellent. So your key takeaway is we should find a space where building the flight data recorder is the key enabler.
Yeah.
I guess the centers of excellence are an obvious place to do that, in fact.
Centers of excellence are. Yeah, and I guess the other thing to add here is that they're not the medical record of today probably isn't that data recorder.
I think we can agree on that.
Yeah.
All right. This is great. A lot of interesting discussion, it sounds like, and I've made a bunch of notes. I hope we can take some of these ideas and we can carry them forward. I would open the floor to questions, but I think maybe a more effective way to go is to thank you now for your service, and we'll close up and move to cocktails, and then people can talk to you individually. That'd be fine. So let's thank our panel and our So let me turn to, I guess, just a few closing remarks about the symposium. Again, first, thank all of you for those of you who stayed through the day. I know it was a long day. We were exploring this theme of teaming with technology along the healthcare spectrum, and for me at least, it's been really a truly interesting tour. And I learned many things that I didn't know. We've basically been through robotics, imaging, diagnostics, clinical decision support, nursing scheduling, all different dimensions of how technology can impact the lives of patients, it can impact the lives of clinicians, it can impact the lives of really all stakeholders in healthcare. What I really take away from this is, back to the genius of the and. I think there's just tremendous opportunity and energy in this institution, and I think more broadly, at trying to bring together some of the people that we had in this room, people that are interested in the people side of the equation, people who are interested in the technology side, but also committed clinicians who really want to bring this technology to bear. So I hope that all of you learned something today. I hope that it isn't a good movie that once you go home you forget about it, but you actually find something actionable in what you heard today. And I think above all, I think I speak on behalf of the Malone Center and the Armstrong Institute. We're both committed to helping teams of people advance healthcare, and we would like to be involved in that process. So definitely come to both of us, both those institutions, if you feel like there's a direction you'd like to take that you saw today. Before we break, I'd be remiss if I didn't say a few thank yous. So first, I want to say thanks to the organizing committee for this symposium. So it's Aisha Gersis, who I know had to leave, Jeremy Brown. Jeremy, are you still here? There's Jeremy. Simon Matthews, Vess, who was kind of note-taker in chief, and myself, of course, but I'm up here. So thank you all. This has been just amazing.